Mr. Rock. That's makes me. It's very questions. It's just times just it's just 35 points. Too much that it's the first report. It's my fifth next stage. So for the right place, judgment was crossing range. Free flowing. How we should all act. Was I my and later they go ahead. Yeah. Sure, one second. Talking about our experiences. Sections, and also from start speakers. Yeah. So check one, two. Second one is Mel, does that sound better? Mel, can you hear me
Yes,
well?
it does. That sounds perfect. Can you hear me?
Okay. We cannot hear you. It's also kind of loud in here, Mel. So try testing your mic again, please.
How about now? Can you hear me now? How about now?
You're quiet, but let me turn you up here.
All right. How's this? How do you hear me now?
All right, try one more time, though.
Can you hear me now? How about this? Does this sound any better? What do you think about this?
And Charles.
That's kind of fun. I didn't know that the first
Mhm.
presentation is control for it. It's just.
All right, one more time now, please.
How about now? What about now? What do you think about my volume now? What do you think?
It's cool.
Uh-oh, I can't hear you anymore. The choppy thing happened. What do you Can you hear me?
I don't like the envy, but introduce this week.
Yeah. That's all I gotta do. But I'm figuring out this sound thing with Mel right now.
Okay.
So Mel, could you share your screen, please?
Sure can. I have disabled the participant screen sharing. Would you be able to make me a co-host or something?
Yeah. Let's make that fall. It's forever.
All right, Mel, we've made you a co-host.
Hey, how about now? Can
Okay.
can you see my screen?
My screen. It's good.
How about now? Can you hear me now? Every time I keep speaking, I keep getting muted. There's feedback. How about now? Can you hear me now? What do you think about my volume?
Yeah, no, I kept getting muted too.
What's that?
Mel, it says I'm muted right now.
How about now? Can you hear me now?
One more time, please.
How about now? What do you think about my volume now? Does that make any difference right now? I just changed my mic setting. Sierra, can you hear me? Okay. We can hear you on Zoom land. Okay. Am I the only person you can't hear in person?
I gotta turn it on. There you go.
How about now?
Yes.
Oh, thank goodness.
And whose sound are we not getting?
Mel, our speaker.
Yeah,
I mean, we're
listen.
not getting another.
She's supposed to be remote?
Yes.
Okay.
I've got check the DI channel. It's good.
Okay. Well, we are live here. Mel, say something?
What about now? Do you think you can hear me a little bit better?
Give it up. Okay.
Guess not.
Go ahead, Mel, say something else.
How about now? What do you think about my volume?
There we go.
Oh, thank goodness. Thank you for problem solving that. Thank you for putting all the moving pieces together.
So Mel, how are we doing this presentation? Is she screen sharing something?
I'm screen sharing something. How about this? Can you see
There we-
this? Okay, one more thing I want to test is I want to share a video with sound.
Yep, go ahead.
Sharing sound and
forward is a collaborative system. Everybody wins that way.
Yep, we can hear it. We can hear it.
you can hear it. Okay, great.
Oops. Full screen. All right. Show's yours.
Okay. Welcome, everyone. My name is Debbie Reynolds, and I identify as she, her. I'm your moderator for this for Diamond One. This is my first opportunity to present, to assist with this presentation. So I'm kind of excited and nervous at the same time, so bear with me as I fumble through this process. So I'm going to let Melissa introduce herself.
Okay, hi everybody. My name is Mel Hauser. I use she, they pronouns. And my colleague, I'll let you introduce yourself, Sierra.
Hi, everyone. I'm Sierra. I use she, her pronouns.
Great. So we are here to talk about practical strategies for delivering neuro-inclusive healthcare. That is healthcare for people with all types of brains whose minds work in all kinds of ways, who currently often struggle to access healthcare. Sierra, do you want to walk us through our objectives?
Absolutely. So we're going to talk today about the systemic barriers to healthcare access for neurodivergent people, and talk a little bit about the pattern of kind of neuroimmune conditions commonly experienced by autistic and ADHD patients, and then try to list some concrete and actionable steps that anybody can use in any environment to support the needs of neurodiverse patients. So we are family medicine trained providers, as well as clinical focuses in neuroinclusive healthcare, as well as a few other types of clinical focuses. We are a toddler nonprofit. We've been around since 2021, and we provide a novel access of healthcare delivery, integrating social connection, employment support, and education into medical care, which we will talk more about. What we know in 2024 is that we all have different types of brains. We all have different ways of sensing, processing, thinking, behaving, communicating, learning, everything. We all have unique patterns of strengths and challenges. We know that universal design is best practice, universal design being offering things in multiple different ways to meet the access needs of everybody. In short of this, we like to focus on designing supports and accommodations to fill in the gap between the access needs of people and the societal and systemic structures that are in place. We do not focus on treating or fixing or complying with defaults. We know that at least 1 in 5 people think, learn, and communicate differently than the majority of brains. This is what we're talking about when we're talking about neurodiverse populations. And we know that, especially for this 1 in 5 people, one size fits all does not work for everybody. When we deliver things in a one size fits all format, we know that leaves people out. Specifically, we know that neurodiverse people experience health inequity and struggle to access healthcare, as well as other critical aspects of life, including education, employment, and social connection.
I want to tell you a little bit about the experiences of the neurodivergent people that we care for at All Brains Belong. When I use the word neurodivergent, I'm referring to that at least 1 in 5 people whose brains or minds work in ways that significantly depart from the type of brain that society most often caters to. Society most often caters in a one-size-fits-all way. So I'm going to play you a video from one of our patients talking about what it has been like to access healthcare. Can you see this video before I hit play? Sierra, can you see it?
Yes.
I'm terrified to go. I can just feel when I walk in, I don't know if it's a safe space for me, being neurodivergent, but I also don't know if it's a safe space because of the way that I'm going to be treated and disregarded in terms of like, just go lose weight.
Nobody believes you. Everybody looks fine, so it has to be fine. Understand, everybody's access need is different. We're all different. We're not the same. Sort of designed for you show up and they send you places and put you in little cubbies and folders. And if you actually are like, no, nobody quite knows what to do with you.
Because this presentation is so short, I'm not going to be able to share more videos, but we have a free community education program called Brain Club every Tuesday night at 6. And all the archives are available for the past 3 years for free. And so we frequently cover the experiences of neurodivergent people in healthcare. So if you're interested, we'll share that link so that you can really immerse yourself in the experiences of what our patients, what our community is telling us the status quo of healthcare feels like in Vermont. And beyond Vermont, we know that the literature says that there are extensive barriers to healthcare, and that focuses in these 3 clusters: healthcare interactions with the environment, with people in the environment that might relate to sensory processing, communication. Neurodivergent people perceive that healthcare providers have inadequate knowledge and skills to provide healthcare to them, and that they harbor unhelpful attitudes. And a lot of that relates to the narrative, the hidden curriculum that is embedded in medical training. And when we think of the system, there are so many defaults in the healthcare system. You must pick up the phone to make an appointment. You must fill out the 20-page packet to become a new patient. And when that default is a mismatch for what patients need to access something, not only are they othered, but they are prevented from accessing healthcare. And related to the knowledge, what we know is that neurodivergent people are far more likely to experience chronic health conditions. In our medical practice, 97% of our autistic and ADHD adults have a constellation of neuroimmune conditions that I did not learn about in medical school, impacting all of the systems in the body. Some examples, this is not an inclusive list by any means, examples of the medical conditions that belong to this constellation of medical problems. This is what almost everybody here, and we care for a patient population whose needs were not met by the traditional healthcare system, and among that group, 97% has this constellation of neuroimmune conditions that are poorly understood and poorly even known about in medical education. There's also a problem with the way that healthcare providers are trained about autism, ADHD, et cetera. So looking at this study, Zerbo et al., 10%, less than 10% of primary care physicians would suspect their patient is autistic if the patient volunteers information, shows interest in people, discusses emotions, and can see the whole picture. As an autistic person, I find this disappointing. There are also so many words, the words that we use as professionals often reflect the paradigm that we're operating in. And our patients share with us that when they hear healthcare professionals using words like autism spectrum disorder, comorbid, functioning labels, they feel unsafe. They feel unsafe because it reflects a professional that is operating in a deficit-based paradigm. But that's not why we're talking about this. We're talking about this because neurodivergent patients are dying. Autistic adults have an average life expectancy of 36 to 54 years, with leading causes as cardiovascular disease and suicide. Autistic adults have a 4 to 9 times higher risk of completed suicide. ADHD adults, 4 times increased risk of premature death. I didn't learn that in medical school. And when I learned that shortly after receiving my own autism diagnosis, I was 37 and the parent of a then 4-year-old autistic child. So for me, that was a hard stop. Why was no one talking about this? Why did no one know this? And that's the story of All Brains Belong. We have to do better. We have to do something different. We have to zoom out and recognize that healthcare is more than medical care. As Sierra shared with you, all of these other domains of health, all of these other domains of life, why do we need to distinguish healthcare from the rest of life? And so here we don't. Sierra, do you want to talk about our programs?
Yeah. So, as Mel said, we know that to do anything, we have to do everything to improve the health of people. We also have to focus on social connection, educational trainings, and employment support. So we integrate all of these programs into our medical care. Our medical programs look like providing medical care to neurodivergent kids and adults. We support the medical conditions more common in neurodivergent people that Mel had mentioned, things like hypermobility, connective tissue disorders, and Ehlers-Danlos syndrome, mast cell dysfunction, and inflammatory processes, POTS and dysautonomia, and long COVID. We provide gender affirming hormone care as we know that the overlap between neurodiverse and gender diverse populations is pretty large. And we provide COVID informed accessibility. Just of note, our practice is currently full, but we invite people to join our community programs that are open to both patients and people who are not currently patients.
All of our programs have been designed, informed, adapted based on the needs of the people we serve. It doesn't have to be complicated. We ask people what they need and we try to do those things. And what we know is that so many of the people we serve, they have felt dismissed, invalidated, mistreated by the healthcare system. They feel unsafe. They feel like they've been left behind. And so much of what we're doing is bringing people together, connecting them with other people who share similar health challenges. We try to help people feel listened to and valued and be able to show up authentically as their true selves and be connected to a community of people who get it. This improves health. Really what we have, our model is that of a community health village of living and healing and learning together. I'm going to play another video.
I get to see people come in who haven't been able to get care anywhere else.
Do you want bright lights, low lights, fidget toys? Do you want to have time check-ins? Do you want to have summaries sent? These things are an option? What?
What interests me about All Brains Belong is the idea of a customizable menu to make an experience, whether it's a vaccine clinic or a medical visit in the office or a community gathering event, feel good to each unique individual.
Being able to cue safety and adapt the environment for what people need.
Like a souvenir.
What do you mean healthcare can be like this?
All right, Sierra, do you want to talk about what some examples of an alternative to one size fits all? Sierra, you're muted. Sorry.
Thank you, Mel. In response to the feedback from our community about what the community needs, we've created these co-created menus that anytime somebody is getting care at All Brains Belong, we have a menu of co-creating the visit environment. So co-creating the setting and how to schedule, how to communicate, supporting executive functioning and environment and sensory tools, which we'll talk more about in the practical strategies. We also think it's important to continue to ask the community what they need. As our model evolves and grows, it is important for us to continue to ask our patients what is currently working and what barriers there still are to accessing healthcare. This last year, we were able to get feedback from 70 patients for feedback and shared experiences through focus group surveys and one-on-one interviews. Following best practice, we were able to compensate our patients for sharing their lived experience. Along with being best practice, compensation is a really important part of accessibility, especially when looking to get feedback and shared lived experiences from marginalized communities. And from this, our patients identified these 5 major strategies for creating neuroinclusive healthcare. These are all centered around addressing access needs being anything needed to meaningfully participate in our environment. These are practical strategies that ideally can be incorporated in most healthcare settings. The first one is adapt the environment, support people's sensory and environment needs. This is what our office looks like. A lot of our patients have a lot of negative healthcare experiences and trauma. When those of us who have healthcare trauma walk into environments that feel like or remind us of these places, it activates our limbic system and interferes with our ability to access healthcare by interfering with communication and executive functions. So doing whatever we can to make a healthcare environment inviting and safe is a really important part of accessibility. As I showed, our environment does not look like a traditional setting, but there are things that you can do in most every setting. Have different options for the environment, outdoor visits, car visits, telemedicine, change the environment when people are in person. Are there options for different types of lighting? Are there alternatives to fluorescent lights? A different furniture choice, options of background music, maybe leaving an exam door open if possible, while maintaining privacy. And then really kind of normalizing and using grounding and focus tools. I think it's important that these are things that patients can ask for themselves, but also that providers can offer and normalize these things, as when neurodivergent people don't know what options there are for accommodations or accessibility, it's hard to ask when you don't know what those are. So normalizing them is important. We know there's no one right way to communicate, and supporting communication is a really important part of accessibility. This can look like having lots of different ways for people to be able to communicate with a healthcare organization, emailing, texting, communicating online, multiple ways to communicate between appointments, including things like requesting refills. We know that specifically phones are a really difficult mode of communication for neurodivergent people to access. We have a lot of research about this. And so offering options like emailing or texting versus phone calls is really important. It's also important to offer different ways to organize information and communicate during visits. So we try to share what questions we're going to be looking to ask, what types of information we're going to be looking to get from a visit with people beforehand, so they can think about their information, organize it, write it down, and send it to us in an email if they prefer versus talking about it. And then during the visit, normalizing lots of different types of alternative communications. Texting, writing, drawing. We have people who, sit across from me in the office and are texting because that's their preferred way to communicate, and that is a better way to get information across.
The next thing I want to talk about is executive functioning. When I worked in the traditional primary care setting, there was, and many different settings, there was a lot of stigma and judgment when patients missed their appointments. There was often an inference of, this person isn't motivated, this person is engaged, this person, they never do the thing. Really, this is part of many people's disability. There is so much executive functioning skill required to access healthcare, from the actual making of the appointment to the getting there to the timing and scheduling. Like, this is part of people's disability. And so what happens in traditional healthcare? Somebody misses 3 appointments, they get kicked out of the practice and can't come back. We have to figure out how we're going to negotiate and navigate conflicting access needs. We're a small nonprofit practice. We have to see a certain number of patients every week in order to stay open. We have to figure out how we're going to bridge those gaps so the patients are actually able to access care. And so some of the ways that we do that, lots and lots of reminders in lots of different ways, because reminders in one size fits all does not work for all. Many of our patients are really dependent on recalls. So we have systems that, hey, we haven't seen you in 6 months and we're going to recall you for this. Or, oh, we just made a medicine change and we are going to recall you in a couple of weeks. So that ends up being a really important structure for people who aren't able to access that on their own. Sierra shared, pre-visit planning, and being able to send a copy of that pre-visit exchange to the patient as a visual support is really helpful. We often are making written agendas for how we're going to use time together. We offer, when people need, hey, we've got 10 minutes left. Hey, we're halfway through the visit, like just normalizing these kinds of supports. And of course, leaving with concrete action steps sent in the method that the patient chooses. Also, when we think about all of the stuff that has to be done to access things outside of the encounter with you, making calls, doing research, creating visual supports to actually be able to engage in the healthcare that you co-created, you can do this with people during appointments, and they need it. A lot of people really need that kind of support. And then diagnosing and managing complex chronic conditions. So we shared before this constellation of neuroimmune conditions, but I want to give you a quick tour of what's available on this website that I'm going to put in the chat. So this is the main site. I can't make it bigger because I'm just giving you a marker to tell you to go to this website. And there's a link to a clinician version. Clinician resources, which includes a guide for primary care clinicians. It's a free 16-page management guide that was co-created by a task force of interdisciplinary professionals, including multidisciplinary physicians and OTs and PTs and SLPs and patients, elevating the wisdom of lived expertise, with the idea that not only are there evidence-based management guidelines, but actually in this constellation of intertwined medical problems, sometimes the standard medical management of some parts of this cluster make the other parts worse. And the only reason we know that is from our patients. We also have a tool for patients where they can print out a letter and bring it to their primary care appointment, trying to bridge the gap. It's a letter written in language that doctors are used to receiving. So we encourage you to check that out. All right, last pearl, Sierra, you want to talk about COVID?
Yeah. So the last big thing that patients identified as a really important aspect of neuroinclusive practice is preventing COVID. We know that neurodivergent people are at pretty significant increased risk for long COVID. We know that hypermobile people are increased for risk for long COVID, and people in this kind of constellation of chronic medical conditions. We know that the more times you get COVID, the higher risk you have of getting long COVID. And we know that long COVID has really significant effects on people's lives. We know that long COVID increases the risk for dementia, as well as other conditions like diabetes and autoimmune disease and cardiac disease. We know that long COVID can leave people bedbound, can reduce ability to have employment and social connection and all the other things that we know really are big important parts of quality of life for people. And we know that the only way to not get long COVID is to prevent getting COVID.
In our medical practice, just to add, 25% of our practice has long COVID. Our youngest patient with long COVID is 5 years old.
And this was really reflected by what our patients said. Our feedback from our community is that COVID safety is of critical importance. Some things that our patients shared: I haven't gotten healthcare because I don't want to get COVID from an unmasked doctor or in the waiting room. You're the only practice I found in Vermont that is COVID and long COVID informed. At All Brains Belong, I don't have to choose between getting healthcare and my health, which is a choice that nobody should ever have to make. Nobody cares anymore. My life is ruined and the world keeps going like nothing happened. I would just note on here that I think we have some really good evidence that social isolation is a really significant risk factor for lots of different negative health consequences and outcomes. And the social isolation that happens with long COVID is pretty significant, especially in healthcare settings. In healthcare, we know the ways to reduce COVID in healthcare settings. We know well-fitting masks, ventilation and air purification, offering options like outdoor appointments or the first appointment of the day before other people are in the office. We also recommend both patients and providers to connect with local disability advocacy organizations for support around requesting accommodations and offering accommodations. We receive a lot of support and work very closely with Vermont Center for Independent Living and Green Mountain self-advocates.
The other thing I'll add, it's important to note that the primary way COVID is spread is airborne, in the air. And so what I see often is, patients trying to access, like getting their blood drawn, and we call ahead and we're said, well, yeah, the patient can ask us to put our masks on. Well, the COVID's in the air. So people don't feel safe and they're avoiding getting their labs drawn, going for mammograms, like getting their colonoscopy. Like they don't feel safe. So more resources. Our patients asked us to train the community because of all the places they don't feel safe and included. And so we offer educational trainings for healthcare practices, employers, a wide variety of organizations for anyone who is interested in improving their neuroinclusivity. Also, I'll put in the chat our free community education program every week, including tonight. That's Brain Club. And then I'm going to close out with one more video and then we'll take some questions.
And what I want to see forward is a collaborative system. Everybody wins that way, and it's more collective.
ABB is sort of like, there is this kind of social justice, like you are not the problem. The problem, we have a world that needs changing. Instead of like forcing people to change or like getting in people's face about change, the approach is just to show people that it can be done and do it really well. And that, I just think that's just such a beautiful model and a beautiful way of like creating the world you want to live in. And anyway, I think that's inspiring.
So this is about beginning a relationship. We invite you to get connected with us. Sign up for our newsletter. We send out free resources once a month and connect with our programs. Okay, happy to take questions. First question, the question is it fair to assume that 1 in 5 medical providers is neurodivergent? I can't speak to that. But there is an interesting Medscape article that as we're going through the second question, I will try to pull up that Medscape article about neurodivergent clinicians. That's really interesting. So another question, does All Brains Belong have resources for folks navigating MyChart and other digital portals? So most digital portals are not inclusive. They're not accessible. You can't be inclusive if you're not even accessible. So the idea, the executive functioning load of having like the password and the multi-factor authentication and like all the things, people just, they can't do it. They can't access it, some people. Some things that can be helpful are visual supports. Like the step-by-step of how you access this. So like we made like screenshots of logging into the UVM portal with step-by-step of this is what you do. Because people they can't. Oh, thanks, Sierra. That's great. Happy to take other questions if anybody has any. A great question. So there's a question about why hypermobile and autistic people are more likely to experience long COVID. And that relates to this constellation of neuroimmune conditions. So what was not part of my medical training is that autistic and ADHD people have underlying physiological differences relating to the autonomic nervous system and, as Sierra described, the immune system, in particular, mast cells. And if you go through our clinician guide, it links to, dozens and dozens and dozens of evidence-based resources that connect the autonomic nervous system and the immune system to literally every commonly occurring medical condition that autistic and ADHD people experience. It's all one thing. That's my summary statement. It's all one thing. You zoom out, the autonomic nervous system goes through the whole body. The immune system goes through the whole body, and not surprisingly, when you have mast cells in every organ system, any symptom that you might see in practice, you can really drill down and say, hey, if I zoom out and support the whole of someone, and the healthcare system gets in the way of that, the healthcare system that says, you must see a patient every 10 to 15 minutes, it's very hard to zoom out and address all of the medical problems. It gets so fragmented, right? And so when you fragment this constellation of intertwined medical problems, where sometimes the standard management of some parts of that cluster make the other parts worse. For example, someone has chronic pain, they get prescribed a muscle relaxant, they actually have an underlying connective tissue disorder like hypermobility, hypermobile Ehlers-Danlos syndrome, which is very, very common, much more common than I was ever taught. Now that muscle relaxant made the floppy connective tissue floppier, and their underlying unidentified sleep apnea, for example, gets worse. Their floppy airway gets floppier, and now their dysautonomia gets worse, which makes their pain worse, which makes it's anyway, you just like chase your tail, and this is why these patients don't get better when you fragment their body parts. Sierra, I don't know if you want to add anything.
No, I think that was a great explanation. It's all one thing, and when we look at it as all one thing, then we can do small things to address multiple different aspects of somebody's health.
Awesome. And a lot of these interventions are like super benign, like antihistamines, for example. Antihistamines that are no longer covered by Vermont Medicaid. So we have patients who were clinically doing really well and now are no longer able to do well because they can't access their evidence-based benign medications. So from a health equity lens, I think that's important to name today. Thank you so much.
There you go. Then maybe she can hear. Oh.
Melissa? Oh. Okay, we're running late. Okay. Well, I want to thank the team for their presentation, and we need to move on to the next presenters. Thank you. We'll give a round of applause, please. We'll just log off. Or do we have our university companies?
That's the way you're going to, yes.
Yes. Mm-hmm.
And is there anyone to make sure that it's like when you had that question in the room with the microphone that she didn't hear you from the.
Oh, she didn't hear.
No, I just asked her for the chat and she didn't hear the question. I may be having it recorded on my computer, but.
That should be all set.
Technical difficulties, I guess.
Yeah. Mm-hmm.
Is there any way to know for sure that
So not.
on Zoom can hear now? That can the people on Zoom can hear?
Should be able to, yes.
Okay, so I don't have to do anything on my end, right?
No, you guys should be all set.
Okay.
And I will pass the microphone if.
Kathy, this is your presentation.
And is that right? And so is it easiest, post? Oh. Okay, and you can Andrew, how are you too?
Well, this one is for Q&A. Yes. If we have to make sure that people on the Zoom can hear everything as well. So.
Is this on? Then this is on. So. Okay. Do we have to pass this?
It's how. Anybody has more questions?
Yes.
Thank you.
Oh.
Well, I hope you can still hear us because that was a fabulous presentation. And I think it's actually a really great lead into what we're going to talk about because it's another aspect of healthcare that is unspoken and somewhat, I wouldn't say maybe not taboo might be too strong, but talking about spirituality in healthcare isn't that much different than talking about neurodiversity. It's just not done very often.
It's not, and that's one of the reasons why we chose this quote from Bishop Desmond Tutu to kind of get things started with our presentation, that everything you do is spiritual work, because it's a different orientation towards how you might approach a whole person's wellness and the well-being. And it might be something to write down at the top of that notepad and kind of ponder for the next 20 or 30 minutes of everything you do is spiritual work and what that might mean for you. Cool.
Do you have to be perfect?
I'm not sure, but more time to ponder that question.
The slides not moving.
Oh, it did.
It did. I love technology.
So, really important that we give full credit to ISPEC and a professional spiritual care education and curriculum where all of our presentation stems from today. Andrew and I did a 2-day course on talking about spirituality and healthcare, and we're going to put it together in the next 20 minutes for you. So hang on. ISPEC is part of the GW Medical School's Center for Spirituality and Health. So they have tons of programs that you're interested in really actually learning about it. They actually have a course, the 2-day course coming on in the next couple of weeks.
All right, and then our objectives, hopefully right in the next 20 minutes, you will gain a sweeping knowledge about the importance of screening for patients' spiritual preferences and practices across different healthcare settings. It'll be better to understand a broad definition of spirituality as it pertains right, to diverse patient populations and how it's related to health outcomes, and gain increased confidence in introducing the topic of patient spirituality and respond to those preferences within your healthcare experience.
Translation, we really hope to have spirituality not be excluded from the whole person's identity and healthcare experience. Andrew and I have a couple disclosures that aren't financial, but impact, I would say, our experience of the world. I'm a cis white, married, heterosexual female. I come to, and a family physician. So I come to this work with who I am, which we think is really important, that we see ourselves so that we are able to actually connect better with people who are different. Andrew?
Yeah. And as a chaplain, I have hardly any financial disclosures, but I am a cis white queer partner Jewish interfaith chaplain, and I work in the ED at the medical center.
So we're going to turn this over to you to tell us if somebody could just throw out a definition of spirituality as we start, because we'll give you the textbook version. So, sorry.
The belief in something bigger than yourself.
Okay.
I was just thinking, excuse me, of something that helps you make meaning and feel connected to purpose.
And honestly, they're not plants in the audience.
Superpower. That's my new overlooking you. And protect you. And I believe that can give you like a sense of comfort and safety.
Yeah.
Spirituality is not just one.
Yeah, hi. Spirituality is not just one thing. It's not one size fits all.
For some, spirituality is about believing in God. I guess that's the same as what she meant. She meant when she said so, believing in something that's bigger than yourself. It's also about reflecting about your place in the earth, I mean, in the spectrum of things, and where you came from, and faith, having trust that something bigger than yourself, which for some it could be God, can heal you and can protect you and can help you make meaning of things.
Thank you.
Okay.
Andrew, can you read the?
Yeah, I'm happy in my most chaplain voice to read the definition of spirituality. Spirituality is a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, transcendence, experience, relationship to self, family, others, communities, society, nature, and the significant or sacred. It's expressed through beliefs, values, traditions, and practices. So almost everything that was said in the room, right, can be incorporated in these more formal definitions. All right. So why is the spirituality important? Why is it important in a healthcare setting? Because it addresses so many of these things that all people need, right? And these were touched on: meaning and purpose, connection, peace, transcendence being quite a large one, right, to accomplish in a medical setting. So that one might not be something that would be addressed, but the lack of things, right, will show up and the health and well-being of someone, especially if they're sick, especially if how they navigated the world, right, with their body and the way that they understand it to, be in the world appropriately. Something happens, there's some sort of fracture, and now the way in which they understand the world as they related to it outside of themselves has changed, and it will affect, right, connection, peace, meaning and purpose, transcendence, because that relational aspect may not be there, and that might show up, right, in the office.
So why is this important to healthcare? Andrew just touched on, and as a family physician, like this is obviously Andrew's realm, and what do they call it? Stay in your lane. So it's often seen as something we talk about at the end of life, advanced directives, hospice, and as a primary care outpatient provider, kind of pushing that that current way it's presented in healthcare as actually about the whole across our lifespans. Studies do show that people do want their healthcare providers to be interested in this aspect of their life and that it does impact their health. What you believe, practice, and hold true is an important aspect of your care.
Yeah. All right. So addressing spirituality and religion improves health-related quality of life. Big question. I'm from the school of, I think you have all of the answers, and we just kind of put those answers up into slides. How do you think spirituality might improve a healthcare outcome for someone? It doesn't have to be super cute. It can be minor.
I mean, I believe that spirituality can improve health outcome just in the sense that I don't know, I worked in addiction treatment for a long time. So the idea that, the collective power of community is really healing, because we're not meant to be individuals surviving in isolation. We're meant to be surviving in community.
Definitely. Anyone else?
I was just going to say, for contextual reasons, so my mom is a agnostic atheist, and I was raised Catholic by my father. And when I was 13, my mom had a stroke, and she was being taken back for a thrombectomy surgery. And the medical team did a Christian-based prayer over my mom. And so I think what's really coming up for me right now is someone that is spiritual, not knowing what that is, knowing that there are benefits, but trying to find what that means and how we can have these positive relations or positive outcomes, spirituality connected to quality of life. I guess it's just interesting to see how it intersects and all it can be positive, and I'm just very open to learning right now, but I just wanted to disclose that while we're talking about it. Just mean I'm very open to it.
Just to clarify, was that done without your mother's
yeah,
is that in that moment that was what she asked for?
No, she wasn't stabilized at that point, and looking back on it, I mean, how much sentience do you have sometimes as a 13-year-old, but looking back on it now and reflecting with her, we both can see that it was a pretty inappropriate thing, as people that do have a different spiritual belief than others. And so I think just I've always had a weird relationship with it, but I'm trying to, as I mature and as I grow as a human, try and make sense of what I believe in and how I can exist with other spiritualities. But yeah.
Thanks for sharing that. I hope as we move forward, I think the proposed model would prevent something like that ever happening. Were you all set with your thought? Yeah, go ahead.
Okay. Sorry. No, I was just, I was being respectful. I think the way, in my opinion, the way spirituality connects to our health, we are mind, body, and spirit. We are all connected. We are whole humans. And when we separate those things, that creates a physiological response within us. And so when we have that relationship to spirituality, whatever that may be, because that's a very personal thing. Spirituality doesn't look the same for everyone. It doesn't feel the same for everyone. But when you have that spiritual connection within you to whatever it may be, it does all of the things that are listed on that slide, which provides what your brain needs. When you have thoughts that are overwhelming, you feel it in your body, you have the physiological response, all of those things. And so when you have that spiritual connection and something to hold on to, it improves our health because we have something that can ground us. We have something to calm our nervous system. We have something to give us peace when we need that. And so having something, whatever that may look like for anyone, could be a tree for all that matters. It's really helpful to improving our health and our quality of health and well-being.
So if anyone's wondering, when you send those secure chat messages, if you put critical on it, that's the sound it makes.
I just have a question for you. Are you defining spirituality and religion as the same thing?
No, but I think it would help as we move forward. The next FICA slide, I think, will define more clearly what we're talking about in the health, as we're talking about it in the healthcare setting.
All right, so here are some signs, right, of spiritual distress or someone who may need additional attention to the spiritual dimension of their health. When there's been a loss of dignity, when there's some meaninglessness, which can also be a lack of meaning, or the ways in which you were making meaning in the world, you don't have access to anymore, and that can become isolating, and that can become part of the journey with your health. Hopelessness or despair, feeling a loss of control, conflict between what you held to be true, those values that maybe someone else gave them to or you developed on your own, that are not able to function with the life events or the illness or the medical malady that you're currently experiencing.
And when I learned about this as a primary care provider, I had this sense of how many people have I treated spiritual distress with Prozac? How many times a day? It was very humbling because I don't explore what else is going on. It's like with Prozac therapy, that model we have.
Because it's I'm trying to speak loudly so you hear me. When refugees come to places where their healing practices are deeply rooted in religion traditions such as Christianity or Islam, the Muslims, it can create a sense of disconnect when they're in settings where practices like yoga or Eastern practices or Western practices are kind of given a platform. And so there's confusion, especially when they're in clinical settings, when they're told to, close your eyes, it's grounding, let's breathe. And they're confused, they don't know what's going on because what they know is prayer. Close your eyes. Thank you, Jesus. That's what they know. And so when it's yoga, it's very disconcerting. It's even harmful for them. And it can also create mistrust of not wanting to come back again. And so there's an opportunity that can be lost because of that experience.
Thank you. Now, I know that there's been studies done on why we don't have this connection between spirituality and healthcare, and the biggest reason has been inadequate training. And I teach the med students on a regular basis, and they don't hear about that. They don't know the language. I teach intimate partner violence to the med students, and we practice the words of how to have these conversations. And we do sexual histories. We learn how to ask the questions in a respectful, supportive way. There's not any words about how to include anything about spirituality in the conversation, so it just doesn't happen.
Right, there's been so many great comments about something happened right to my family that should not have happened, or maybe practices right that you would want to include but aren't included, and the privileging of different types of traditions that may not be the right one for another person. And one way to really avoid that, to make sure we're having full amounts of consent from patients, of making sure we're doing the most beneficial thing that we can for them, is to trust them that they're the expert, right? And what they need spiritually and what their spirituality looks like. And we can get at these in a few different ways. There's a spiritual screening, which we'll talk about, which is just, something that happens on admission or a first encounter of trying to see, is this something that's important to you? Are you encountering these types of issues? How do you feel about the outcome or your prognosis? If those things aren't well, right, that might check off to have a referral to a chaplain. Then there's spiritual history taking, which is a little bit more advanced. It can happen on the initial visit or an annual visit, an acute visit, it's saying here. At least in the hospital setting, that would be the type of information gathering that would occur if things are pretty serious. Or someone uses a lot of theological language, but they're not piecing it together in a way that makes sense to you or their team. And then there's the spiritual assessment, which is we may have to helicopter you out of here. And then we have the spiritual assessment, which is what we're going to talk about in just a minute. The purpose of this presentation of just trying to find out what is going on with someone's spiritual dimension when you first meet them, and how that might be useful or play a role in the care that they receive with you.
So this is a pretty complicated algorithm, but we have algorithms for everything. So I thought it was nice to see, you probably can't read it, but nice to know there is an algorithm about how to do this. It's not what we're going to teach for but I was even impressed that Andrew was like, oh yeah, the Rush protocol, this is actually, there's been research and studies and anything else you want to say?
Yeah, Rush is just sort of like the powerhouse of healthcare spiritual research. The thing that's great about this is it kind of gives you a way to continue or to stop when you're interacting with someone. Does this person have distress? You can keep going. What signs are they giving you? What do you do next? Or sorry, if then if this then that scenario, and then if that, maybe no more. But it helps a non-specialist spiritual care provider or assessor have some pretty good guardrails of you're able to get in there, you're able to get the information you need and to respond to it in an appropriate manner, but not to go beyond what your own specialized training is.
So FICA is the model that through GW's program that they've been teaching all over the country. We did the train the trainer, as I mentioned earlier. That is a very simple approach that anyone can do in any setting with minimal training. FICA stands for faith, and your question about talking about religion, the F is faith, belief, meaning, values. How do you cope with stress during difficult times? It's extremely broadly defined. And if you bring this up, if you just raise that as a question, you're going to have a sense of, the person might be totally no, don't go there, but they might be like, oh, thank you. And then you're going through the I is importance. So how they respond is this important to your health care? The I is how does this how important is this to you, and how does it relate with your healthcare? How does community, a lot of times there's a community connected with how somebody's spirituality is experienced. How is that in the person in front of you? It could be broadly defined as a mosque, a church, family, a yoga group, like-minded friends, going for a walk in the woods with a friend. Those are all the things that create community. And then how do you want it addressed in your care? What's meaningful? How is this important to how you and I work together in providing your care?
And I think one of the great things about the FICA model is it really is designed to be used by non-chaplains, right? By different members of the healthcare team. And so it doesn't require, all of the other things that we do, being very still, being very peaceful. These are questions that you can just ask, right? You don't have to be theological, you don't have to be over empathetic, you just have to kind of gather information any other way that you would do that. And it gives you permission to do, you can see in the verbiage here.
They have done studies on FICA. That's why I call it evidence-based, because we like everything to be evidence-based. Is the lack of training is has been the barrier to using it. But it is part of quality improvement that can be used in any healthcare setting.
Yeah. And now we have the self-assessment tool, because we don't want to assess anyone, right, who hasn't consented to this, but to get a better idea of what it's like to engage with these questions. If you want to take just a few minutes to kind of do your own assessment of yourself, right, your own like a self-exam, if that's something you're comfortable with doing, or maybe just taking a picture to ponder it later, but of kind of thinking about what this would actually be like to experience, so you can better understand what it'd be like for your patients or those within your care to encounter. Yep, we're going to try to get through. Right, so the first question is pretty simple one. Am I a spiritual person? Do I have faith or spiritual belief that helps me cope with stress? What gives my life meaning? A bit more complicated question, but one to consider nonetheless. And if you have time to move down to importance, right? Are those things actually important to you, right? Are those things that you do actually integrate, right, into your navigation of your health and your world? And then a big question, right, in a post-COVID landscape where we all have these communities that existed, and a lot of times they don't anymore, but we still rely on that idea of what they were like. A lot of folks encounter that. And then action. Should you have an action plan around, right, your spirituality? What changes do you need to make in relation to your health? Things may be all good. And in the interest of time, we're going to keep going, but if you did want to share what that was like, we'll have time at the end. All right.
So we don't like the word generalist, but that's the word they use as family physicians and primary care providers. But it portrays the model that's so important, that in everything that we do, you're not expected to be the expert. Because that's one of the other barriers is, I'm not going to ask that. Like, what are we going to say? Like, how am I going to respond? Or what am I going to do? Like, so that is one of the barriers to even having the conversations, is not being the specialist. It's a specialist, but how to respond. So that's why this model of introducing it into the primary care setting is actually a generalist specialist model. Everyone on the team has a role.
All right.
So the clinician's role is just to bring up the topic, assess if spirituality is part of their healthcare, and if there's a stress, and what resources can I connect that person with. In my specific practice, we have social workers. They're not experts either, but they're part of my team, and they would really help me connect somebody with a resource that is appropriate for that person. So I don't need to be the expert. They don't need to be the expert. I could always text Andrew. But we do have a team within our healthcare systems.
All right. To summarize, spirituality is integral to any patient-centered healthcare system. Right, we talk a lot about holistic care, I think, in a lot of the settings that we find ourselves working in, but you can't have truly holistic care without the spiritual dimension being involved. Spiritual distress being treated the same as any other medical problem as something that's important and should be addressed, and also understanding it, right? I love this so much as a vital sign. If someone is in true distress, understanding something is going on here, it might be medical related, it might not be specific, right, to the physical condition of the body, and getting someone
I'm old enough to have been trained at the time when you're supposed to use pain as a vital sign. Like, why not turn that around? That's something more positive as one of the vital signs.
Yeah. And then pursuing the general specialist model of spiritual care, and ensuring that all patients get a spiritual history or screening when they come in, because it may not be useful in that moment. It may be useful if they wind up staying with us for longer than anyone anticipated, right? And then, right, integrating into a whole person treatment plan, right? It needs to be there. If we're going to be honest about pursuing things like that, whole person care.
Just the idea of moving away from where spirituality screening is the intake of checking the box of, like they were talking about the check the box this morning. It's one of the things that gets put on your demographics. Moving it into who the person is and not just not a demographic.
All right. And then spiritual care practiced by our clinicians with chaplains is essential for respecting diversity, equity, and inclusion when we think about what it means to really embrace the full person, the fullness of the individual who presents as a patient.
How about questions? Comments? Really enjoy those. We all learn from all of you.
Have you ever considered doing backwards? Doing this entire thing backwards? When I'm listening to this presentation, I'm noticing that I'm being put to another box, and it feels to me that, like, let's think about going to a physician, and let's think about, like, I have this pain, and the physician puts the anatomy kind of book in front of me and names all these parts in my body and asks, do you think, what this part of your body does, what this, and I'm being thrown all this terminology.
Mm-hmm.
And I'm being asked to fit myself, to define myself with the terminologies that I'm being introduced to.
Mm-hmm.
And this session started with, this is not the same for everyone. And what I'm hearing is more about, the questions or the orientation is to guide everybody with, like, to its same direction, or asking, like, those questions feels like if I come to you and whatever I say has components of what you intend to study in terms of a spirituality in it, in my narrative. It doesn't need to be labeled by your belief system or your value, or do you do this or do you do that? Especially when some of us have not lived a conventional life that many others lived. It's really hard to translate that experience to a language that's familiar to many.
Yeah. Do you want to ask the chaplain on it?
Respond?
Or just
Yeah, I mean, it's difficult when we do try to box people in with 4 questions. It's like, you're here, we're going to ask these 4 things. I think a lot of times when we do have interactions with people for the first time, a lot of this information is provided, right? If you're very skilled, right, with interacting with people, especially when they're under stress or they're facing something more severe with their health, and you can kind of place those things. And it could be, so the coping is okay. The community is there, as conventional or as unconventional, right, as it might be. But this individual doesn't have any connections. Like, there are no meaningful connections, and trying to help maybe steer or reflect back that, right, that connection is really important. And we could, get really into the spirituality, or we could just say, we know that it's really important when people are in the amount of pain that you're in, for them to be as well resourced as possible. And one of those is relying on individuals. Is there anyone that you might be able to call, right, to be with you in this time? And it can be that simple.
And to made me think about one of the things we totally it was on a slide. I don't even know if we glossed over it. Is the idea of reflective, compassionate listening, and all of this is having that just being present and listening is essential to any of this. And when we did the course, it's like, I don't know, 2 hours on reflective listening and practicing. And but I also feel like we are trained to do reflective, like what we would call compassionate listening. We're all trained in our whatever we're doing to be present. And so that's almost has to be the foundation of any of this work, or including this, is being present and listening.
So I'd like to make one comment because this is very important. I had one experience. I'm originally from Congo, and there I'm a physician. First of all, when I finished my medical school, the system in Congo, you have to go to countryside to practice all kind of services, gynecology, pediatric surgery. So I had one case for one kid. He was like 6 months. So they bring him in hospital like for 3 months, every day fever. But in Congo, when we are in medical school, we have one course they call medical anthropology. So, and they teach us how some kind of Western medicine, we have some kind of a limit. And I did talk to the parent if the kid had baptism, because myself, I'm Catholic, and I did orient them to the priest. Since the kid had baptism, and the fever will stop. So there is some kind of disease we can be a limit to treat, but as a physician, we should help the patient. This is the big problem here in Vermont now. The Vermont now it became more diverse. We have a lot of immigrant and refugees. We have some cases they can work at the emergency room, like for 2 years. They can do all kind of exam equipment, but they couldn't find nothing. And the patients still complain about abdominal pain. In Africa, for example, I know one cases, she had like 9 kids with the normal birth in Congo. But here, the last one, they did provide a C-section, or she is multipart for nothing. After that, she keeps have like abdominal pain every day, every single day. She can walk the emergency room. They know her already. If they see her, oh, we cannot do nothing. But we did oriented her to the one priest. She was healing with the prayer, and since that prayer, she's doing well. So this is very important. We should help the medical student here. I know we are going many times to help them about to develop the culture of humility, but this is very important. I don't know here in America, the system, I know you cannot ask someone about religion, but as a physician, because in the African conception, when the patient go to see the doctor, he's like a god. He's gonna give all solutions. But here, it's like I'm so sorry to say that it's like a kind of business focusing on computer and insurance, so it doesn't help.
Thank you for sharing that.
I was just going to circle back to like after listening to everyone's perspectives and watching or listening to you both. I think like I am someone that practices, I lead with grace and humility, and I'm so focused on patient-centered care. And I think that before this, like I knew that I had this bias and have been really trying to dismantle it, but realizing that maybe it's getting in the way of whole person care, patient-centered care. And so even just, you know, 1 20-minute session is not going to, you know, completely deconstruct that. Luckily, I'm in therapy and can work through that with my therapist. But I think just planting the seed and understanding the nuance and expansiveness of diversity, equity, inclusion, and involving spirituality in that is really beautiful. And so I just wanted to say thank you to everyone in the room and then you both too for having a space for this discussion.
Thank you.
Huh? Oh, thank you.
Information. I'm trying to find it. Okay.